2, 1. Good afternoon. It's Dr. John Bennett broadcasting from the headquarters of Neurosurgical TV. Today we're honored to have the broadcast of the Young African neurosurgeons. With another in a series of neuroanatomy presentations. And we have Nathalie here. She's going to tell us a correct name, as well as some other panelists I'm glad to see. Okay, hello, Marco.
Hello, guys. Nice to meet you. For everyone who don't know me, I'm Marco Meloni. I'm a consultant neurosurgeon, and I work in North Italy. Thank you.
Welcome, welcome, Marco. Ulrich.
Hello, everyone. I'm Ulrich Stitney, a final medical student from Cameroon and a research associate at Harvard's PGSST program. Nice to meet you all.
Yeah, we look forward to hearing from Ulrich and Harvard. And with a new arrival, Jack. I don't know, Jack, if you can. Dylan's here. Like, he's coming in now. I'm sorry here. Gotta let him in. Jack, are you there? Can you hear me? Let me unmute you. Jack, MD. Just introduce yourself, could you please? Or okay, there's Jack. Go ahead, Jack.
Okay.
Go ahead, Jack. Can you introduce yourself? Oh, Jack left. Dylan, welcome.
Hello, John. Thanks. I'm Dylan, 7-year medical student from Cameroon. Nice to meet you all.
Okay, welcome. Thank you for coming. Mahai, can you hear me okay? Let me unmute you here. You probably, can you please introduce yourself, Mahai? How you doing?
Hello.
Welcome, welcome.
Hello, I'm from Romania.
Oh, excellent. Great. A friend of Elena.
Yeah, sure.
Oh, excellent. She did a great show today.
Yeah.
Okay, very good. Okay, Nathalie, it's all yours and welcome.
Yeah, hello everyone. I'm Nathalie. I'm a general practitioner, medical doctor in Cameroon. I think I'm the one to present. I'm the one to present today, and I'll present on. Is it okay? Everybody has presented itself. I think
yeah, it's
so,
fine.
John. Okay. Today I'll present on blood supply of the brain, the part 1, and it will be on the. Let me just. It will be on the anterior circulation of the brain. I don't know. Is it? Can everybody see?
Yes, we can see it. You want to make it a little bigger? Or...
Okay.
There you go.
Okay?
Perfect. Perfect.
Okay. Today I'm going to present, or I decided to present on the anterior circulation of the brain. Our objectives, our main objectives will be to be able to describe the vessels that supply the brain with blood, to master the different arterial supply of the brain territories, and to explain how a disruption in circulation would result in stroke or other arterial pathologies such as aneurysms. We will follow a just simple plan. After a brief introduction, we will give some interest of our study, of our presentation. We will give a general anatomy and a detailed anatomy of the different arteries. We'll give while giving their clinical interest, and then we'll conclude. As introduction, we'll say that the central nervous system, like any system of the body, like any system of the body, requires constant oxygenation. The brain has a particularly high demand in oxygenation. It benefits of 15% of the whole cardiac output, so it's quite a big, a large amount. It is also very sensitive to oxygen deprivation, with ischemic cell death resulting within minutes. For the anatomy, we will first do a general anatomy of the blood supply system, of the anterior of the blood supply system. We'll describe. We will describe the circle of Willis, and then we'll enter into the anterior system detailing. The brain receives its arterial supply from 2 pairs of vessels. We have the carotid artery, the internal carotid artery, which originates from the common carotid artery from the aorta, And we have the two vertebral arteries down here, which originates from the subclavian artery, also a branch of the aorta. Both anterior and posterior systems are connected together by the posterior communicant artery. By the posterior communicant artery, and connected together, all of it forms a form of circle called as circus arteriosus, or also known as the circle of Willis. Here we have an image, an angiogram, which shows the different arterial supplies. Here we have the anterior supply. We have the common. On the right, we have the common carotid arteries, which after this, here we have the sinus, which after the sinus artery bifurcates into two. We have the external carotid artery behind, posteriorly, and we have the internal carotid artery, which further courses towards the intracranial part of the brain. Posteriorly, we have the vertebral artery, the vertebral right artery, which originates from the subclavian artery, courses to the transverse foraminus of some cervical vertebrae to the intracranial portion, where it joins to form the basilar artery. We'll first start by the anterior supply. A general view of the anterior supply is mainly done by the internal carotid artery, which arises from the common carotid artery, as here, which arises from the common carotid artery at the level of C4 on the neck. It enters the skull via the carotid canal in the petrous temporal bone. This is the petrous temporal bone, and terminates at the bifurcation into the anterior cerebral artery and the middle cerebral artery. This artery has two portions, an extracranial portion and an intracranial. This is the extracranial portion, C1, and the intracranial portion made up of C2 to C4. The internal carotid artery is made up of 4 segments. We have the cervical segments. The cervical segment extends from the junction, as we saw before, with the common carotid artery to the external orifice of the carotid canal at the temporal and at the petrous temporal bone. The C2 segment, which has a horizontal pattern, courses within the carotid canal inside the petrous part of the temporal bone to an end where the artery enters into the cavernous sinus. This is the cavernous sinus in the sphenoid bone. We have C3, which is the cavernous part, courses within the cavernous sinus, cuts vertically within the cavernous sinus, and ends where the artery passes into the dura mater, that is into the subaranioid space. This C3 forms the roof of the cavernous sinus. We then have C4, which is the supraclinoid portion, which begins where the artery enters the subarachnoid space and terminates by the bifurcation. That's it. And terminates by the bifurcation into the anterior carotid artery and the middle carotid artery. Sorry, the anterior cerebral artery and middle cerebral artery, sorry. Here we have a 3-dimensional representation of the different segments of the carotid artery. We have first the cervical, the C1, which is cervical, which is precochlear. We have the C2, which passes through the carotid artery in the petrous bone of the temporal, the petrous part of the temporal bone. We have the C3, also called as glycerian or clival portion, which passes through, which is intracavernous, passes through the cavernous sinus and ends where the carotid artery enters into the subarachnoid space. Here we have a digital subtraction angiogram, which shows the different parts of the different segments detailing. Here we have C1, which is vertical, then C2, which is horizontal, C3, cavernous, which is vertical, and C4. C4 further, which is intradural, further subdivides into three segments. We have first the ophthalmic segment, then the communicating segment, and the choroidal segment. These different segments gives 1 to 9 perforating branches, amongst which in the choroid segment, we have the anterior choroidal artery, which vascularizes part of the plexus, the choroidal plexus. On the second segment, the communicant segment, we have the posterior communicating artery, which is the main artery which links the anterior system to the posterior system. Then we have the ophthalmic segment, which has 1 to 7 branches, amongst which the ophthalmic artery, which will vascularize the choroid of the eye. On this image, we can see the different segments of C4, amongst which we have we have the ophthalmic segment, we have the communicating segment, the ophthalmic segment which gives the ophthalmic artery, which will go and vascularize part of the chiasma or the optic chiasma or the optic tract. It also gives we have also the communicant segment of C4, which vascularize part, which gives the posterior communicant artery, which connects to the posterior cerebral artery and forms the posterolateral surface of the Willis, the circle of Willis. We also have the choroid segment, which is deep green, which will give the anterior choroidal artery, which is one of the main arteries which vascularizes the choroid plexus. The choroid plexus is very important in the secretion. It's a plexus which is important in the secretion of CSF fluid. For the posterior supply is made essentially by the vertebral arteries. These vertebral arteries, as we said before, arises from the subclavian artery, from the aorta, ascends through the transverse foramina of the cervical vertebrae from C7 to C2, and then enters into the cranial cavity through the foramen magnum, with the anterolateral aspect of the medulla rostrally. These two vertebral arteries will converge, uniting at the junction of the medulla and the bones to form in the midline the basilar artery. Along its course, the vertebral artery will give rise to a number of arteries, amongst which we have the anterior spinal artery, we have the posterior communicant, the posterior inferior cerebellar artery, We also have the middle, usually have also the medullary artery, which we can see here. For the basilar portion will give arteries, the labyrinthine arteries, the anterior inferior cerebral arteries, the pontine arteries, and finally will be the superior cerebral artery, and finally will bifurcate into the posterior cerebral artery, which will take part into the formation of the circle of Willis. We have to note here that there is the posterior, usually the vertebral artery. Sometimes the vertebral artery can the posterior spinal artery directly originates from the vertebral artery, but most frequently we find it originated from the posterior inferior cerebral artery, as we can see here. The anterior and posterior spinal artery will vascularize, will go distally caudally and vascularize the spinal cord. The posterior inferior cerebral artery will vascularize the inferior part of the cerebellum, the inferior part of the cerebellum. The vertebral artery is also made up of segments. We have 4 segments. We have V1, which is a pre-transverse or pre-vertebral segment. It is a segment which originates from the subclavian artery to its entry into the respective transverse foramina. We then have V2. V2 extends from the transverse foramina of C6 up to the transverse foramina of C2. We then have V3, which is the suboccipital segment, which extends from the transverse foramina of C2, as we can see here, to the foramen magnum. We then have the intracranial portion, which is V4, which terminates as the basilar artery, as it unites with its contralateral artery to form the basilar artery at the pontomedullary junction of the brainstem. The posterior supply has cervical branches. Cervical branches or extracranial branches will give rise to spinal and muscular arteries, while the intercranial branches, as we said earlier, will give rise to the posterior inferior cerebral artery, the medullary artery, and the anterior spinal artery. Let's now talk about the circle of Willis. The circle of Willis is the anastomotic system between the anterior and the posterior supply. We see that the anterior supply coming from, as we said earlier, coming from the internal carotid artery, particularly the C4 segment or the intradural segment, will give the anterior, will bifurcate into the anterior cranial cerebral artery and the middle cerebral artery. At its communicating portion, it will give rise to the posterior communicating artery, which will connect the anterior system to the posterior system, by linking to the posterior cerebral artery. Anteriorly, the anterior cerebral artery will join to its contralateral artery by the anterior communicating artery, this forming a whole circle called the circle of Willis, or the circus arteriosus of the brain. This circle of Willis is situated at the inferior part of the encephalon and lies in the subarachnoid space, precisely in the optochiasmatic system. Here we have an image of an angiogram, which shows the 2 vertebral arteries posteriorly, which shows this, which gives the two vertebral arteries, which will give the basilar artery, and the basilar artery will divide into two, giving the posterior, will bifurcate at its end into two to give the posterior cerebral artery, to which it communicates with the anterior. It communicates with the internal carotid artery through this small artery, these three, the posterior communicating artery. Here we have the anterior, we have the internal carotid artery, which will give two arteries, which at its ends bifurcates into anterior carotid artery and the middle the anterior cerebral artery and the middle cerebral artery. The middle cerebral artery further communicates with its contralateral artery through the anterior communicating communicant artery. The importance of the circle of Willis is that in case of stenosis, for example, there is a compensation by the other arteries due to this anastomosis. We have to note that 90% of aneurysms are formed within the circle, and we also have to note that only less than 50% of individuals have a complete symmetric circle artery. That's, we will not find more than 50 out of 100 persons having a symmetric artery, that's having the same on the left, the same arteries, the same sizes of arteries on the left and on the right. Some may even be absent, that's aplasic, and some may either grow less, that is, have an apoplasia. Now let's talk about the system in details. We have to know that the anterior system, which is supplied mainly by the internal carotid artery, through its course, will give collateral branches. It will give 4 major collateral branches. We have the superior hypophyseal branches. The superior hypophyseal branches arises from the third of C4, that's the third of C4 of the internal carotid artery, as we said earlier. It will be below the optic nerve in the supraclinoid area. You will find it also above the cavernous sinus. How does it cause? It passes anterolaterally. This is the superior hypophyseal artery. Hope it is seen by everyone. Which passes anterolaterally to the optic nerve. This is the optic nerve. And anterolaterally below the optic nerve. This is the optic nerve and it's below the optic nerve. It causes and enters the optic canal and the orbit. This anterior superior hypophyseal artery will vascularize the infundibulum of the pituitary stalk. It will also send branches, as you can see, which will vascularize the optic tract, and also the part of the optic chiasma. Secondly, we have the posterior communicating arteries. The posterior communicating arteries forms the posterior, as we saw earlier, the posterolateral boundary of the circle of Willis. As we can see here, after a retraction of the carotid artery, we can see that it originates from the posterior medial surface of the C4 of the carotid artery. It then crosses medially to the posterior clinoid process. Sorry. It then causes posterior-medially, sorry, to the clinoid and to the posterior clinoid process, and terminates into a terminal bifurcation. It causes backward and medially below under the tuber cinereum. The tuber cinereum is a portion situated between the mammillary bodies and the hypophysis and the celatosecum. So you pass below the tuber cinereum, above the pituitary, the celatosecum, and slightly above C3. This C3. This is an inferior view. Sorry, I didn't precise it. It then goes and joins the first portion of the posterior cerebral arteries. While crossing, the posterior communicant artery will give some perforating arteries, as we can see below, which will vascularize, which will take part in the blood supply of the posterior hypothalamus, the anterior thalamus, the posterior limb of the internal capsule, and the subthalamus. This is another image. This is the same image as we saw before. We see the posterior communicant artery arising from the posterior medial part of the internal carotid artery and medially to the posterior clinoid process. It is this since it is an inferior view, it will be above it will pass above the optic nerve, pass above the optic nerve, and will link medially to the first portion of the posterior cerebral artery. These are the perforating arteries that it gives. On the second image, after a retraction of the temporal lobe, you can still see the posterior communicant artery, which causes to go and penetrate into P1. P1 is being closed by the retractor. So the third collateral branch that it gives is the anterior choroidal artery. This is an artery which is usually single and is found, it originates near the posterior communicant artery. There's it. And this is the posterior communicant artery, which links to the posterior cerebral artery. It causes posterior medially behind the the cerebral peduncle. The supremedial, to the uncus. Is the uncus? Sorry, the uncus has been cut. Permit us to see the choroid plexus. To the uncus, where it passes through the choroid fissure to enter the temporal horn. This is the temporal horn. The choroid plexus within the temporal horn. This is the temporal horn of the lateral ventricle. It then crosses along the medial border of the choroid plexus. This medially, as you can see medially. Close to the posterior choroidal artery, this is the posterior choroidal artery, which originates from the posterior cerebral artery. The anterior choroidal artery always supplies the choroid plexus of the temporal horn, but sometimes you can find it supplying also the medial half of the globus pallidus. The globus pallidus is small, sorry, we don't have a good image. Globus pallidus, the posterior limb of the reticulolenticular limb of the internal capsule. It can also supply through its course the optic tract, as we saw here. The optic tract, the lateral geniculated body of the optic tract. It can also supply the caudate tail, the thalamus, the hypothalamus, and the subthalamus, but this is not always. It can do so. A particularity about the anterior choroidal artery is that it has marked interchangeability. It has marked interchangeability with nearby branches of the C4 segment of the IC of the internal carotid artery. That's the posterior cerebral, the posterior communicant artery, and also the MC, the middle cerebral artery. For example, if in case the anterior choroidal artery is hyperplasic, that it doesn't grow much to vascularize, for example, the choroid plexus or these other segments which it doesn't frequently vascularize, the posterior communicant artery will compensate, and vice versa. This is another image which shows the anterior choroidal artery originating from the internal carotid artery. It crosses posterior medially, passes through the optic tract, crosses the optic tract medially, and then laterally at the cruciate system, then penetrates into the temporal horn of the lateral ventricle to vascularize the choroid plexus, which is here. Here is another image. It is an inferior view of lateral view, showing the anterior choroidal artery originating from the carotid artery, the C4 segment of the carotid artery, crossing posterior medially to go and vascularize the choroid plexus. These are other views. This is a lateral view with the temporal part of the temporal lobe has been resected. You see it crossing, entering the choroidal fissure to go and vascularize to supply blood to the choroid artery. The choroid plexus, sorry. An occlusion of the anterior choroidal artery may lead to hemiplegia, a proportional hemiplegia, hemianesthesia, and hemianopsia. How come? Hemiplegia may be because of an infarction of the posterior two-thirds of the posterior limb of the internal capsule, which we saw that it was vascularizing up, but not frequently. We may also have a hemianesthesia due to an infarct of the thalamus that we saw it was vascularizing previously. And usually we also have a homonymous hemianopsia, which is due to the obstruction of the supply of the optic graduation, optic tract, or part of the lateral geniculated body. We then enter into the terminal branches of the anterior supply. We have two main terminal branches, as we said earlier, of the anterior supply. The internal carotid will bifurcate at the end to form the middle cerebral artery and the anterior cerebral artery. We will start by the middle cerebral artery. The middle cerebral artery originates from medial to the Sylvian fissure. This is the Sylvian fissure. The Sylvian fissure is this fissure found between the frontal lobe and the temporal lobe downward, up and the temporal lobe downward. It courses laterally, laterally to the optic chiasma. It's lateral to the optic chiasma. Below the anterior perforated substance, which is usually found here, and posterior to the olfactory tract into the medial and lateral olfactory tract. Here we have an image, a perianal cut of the cutaneous exposure of the circle of Willis. We see the middle cerebral artery, which causes laterally to the optic chiasma. While cursing also gives some perforated branches, perforating branches, which are known as the lenticular striated. These lenticular striated arteries vascularize the putamen, the head of the caudate nucleus. So we can see that after a retraction of the temporal lobe, we can better see or clearly see the middle cerebral artery and its course to the Sylvian fissure. This is the frontal lobe, this is the temporal lobe. After a retraction, we can clearly see the course of the middle cerebral artery through the Sylvian fissure. The course of the middle cerebral artery, as we said before, courses below the anterior perforated substance, gives rise to a series of perforating branches, as we said earlier, called the lenticular striated branches, which will vascularize the putamen. It then divides within the sphenoid fissure and turns sharply posterior superiorly, as you can see, at a curve called the genu, to reach the insula, the surface of the insula. It's the insula. At the periphery of the insula, the branches pass medially as it's coming down. It passes to the medial surface of the opercula of the frontal lobe, temporal lobe, is it? The opercula of the frontal lobe, temporal lobe, and the parietal lobe. The opercula is this lead which the frontal, temporal, and occipital lobe and parietal lobes produce to cover with their hemispheres to cover the insula. On the second image, we have an external view after a retraction of the frontal and the temporal lobe. We have a better view of the middle cerebral artery, which originates from the internal carotid artery laterally and gives different branches. The middle cerebral artery is also divided into 4 segments. We have the sphenoidal segment. The sphenoidal segment begins at the origin of the middle cerebral arteries and extends horizontally within the depth, deeply into the Sylvian fissure, as you can see here. And ends at the genu. We said that the genu was this flexion, this 90 degrees flexion that the artery does to enter into the insula, the surface of the surface of the insula. We then have M2. This M1 will give, as we said earlier, perforating arteries. perforating arteries known as lenticular-striated arteries, which should vascularize the head of the caudate nucleus, the putamen, the claustrum behind, and the preclaustrum behind. The M2, which is the insular segment, it begins at the genu, as we saw earlier. It passes through the lumen of the insulae, yes, and ends into the circular sulcus of the insulae. This is the circular sulcus. The M2, that's the insular segment, is the main arterial supply for the insula. Then we have the opercular segment. The opercular segment will begin at the circular sulcus and ends at the surface of the Sylvian fissure. That's here. The branches forming the M3 segment closely adhere to and cross over the surface of the frontoparietal, that's the frontoparietal and temporal opercula, to reach the superficial part of the Sylvian fissure, that's laterally. It then forms the M4, that's the cortical segment, which begins at the surface of the Sylvian fissures and ends at the cortical surface of the cerebral head, the frontal, parietal, and temporal cerebral hemispheres. Here we have a branch of M1, which will cross horizontally and then ends at the genu, this 90-degree bend, to form the M2, which crosses in the lumen of the insula and ends at the circular sulcus. This is another, the second image. We can see M1. After a retraction of the temporal lobe, here, we can see M1, giving lenticular-striated arteries, the lenticular-striated arteries, and then continue into the depth of the Sylvian fissure, forming the M2, bifurcating into M2, which will vascularize the insula. The MCA, the middle cerebral artery, has 12 cortical branches. This 12 cortical branch originates from the cortical segment, that's M4 of the middle cerebral artery. As you can see, these are the 12. We have the orbitofrontal artery, the prefrontal artery, the precentral artery, the central artery, the anteroparietal artery, the posterior parietal artery. We have the angular artery, the temporal occipital artery, the posterior temporal artery, the middle temporal artery, the anterior temporal artery, and the temporal polar artery. These cortical branches will supply the majority of the lateral surface of the hemisphere, as you can see. It also vascularizes the insular and opercular surfaces, as we saw with the branches of M2, that's the insular surface and the insular segment and the opercular segment M3. It also vascularizes the lateral part of the orbital surface, as we see here, of the frontal lobe and the temporal pole. This image shows different anatomic presentations of the brain in a frontal aspect. So we can see here M1 crossing into the Sylvian fissure, giving M2, bending at the genu to give the M2. Then M3, which comes from the circular sulcus of the insula, outwards towards the superficial surface of the opercula, and then giving M4, which vascularizes the cortical surfaces of the frontotemporal parietal lobes. These are another presentations of M1, giving lenticular striated arteries, which will vascularize the, as we said earlier, the head of the caudate nucleus and the putamen. Another image. This is a superior view. This is a superior view of the middle cerebral artery, which is originating from the internal carotid artery. These are the lenticular striated arteries, these tortuous arteries that are being seen just by the sides of the middle of the M1. And then we have, it bends, as we said in the journal, to give the M2 and M3. And these are the same images. As clinical value, we know that the occlusion of the middle cerebral artery will lead to motor weakness. Which is caused by the involvement of the corticospinal tract of the central gyrus. This motor weakness will not be proportional. It will have the upper limbs will be more more weak than the lower limbs, because it's back on with the homunculus of Penfield. We can see that we know that the upper limbs and the face are being found on the cortical parts of the external cortical parts of the different lobes. We can also have motor aphasia due to the resulting from the involvement of the posterior inferior surface of the frontal cortex of the dominant hemisphere. That's for somebody who writes with the right hand. If he has an infarct of the middle cerebral artery in the left frontal lobe at the posterior inferior surface of the left frontal lobe, it may result into a motor aphasia. We can also have visual defects, impairment of discriminating sensations, and neglect. That's for the non-dominant lobe. Impairment and discriminating sensation and neglect of space and body parts may result in the involvement of the parietal lobe. That's finger anosmia, right-left disorientation, acalculia, and agraphia. This syndrome is known as the Getzmann syndrome. This is caused by an occlusion of the parietal and occipital lobe of the dominant hemispheres. You can also have a receptive aphasia, which could be caused by the occlusion of the temporal parietal area. Secondly, we have the anterior cerebral artery. Anterior cerebral artery arises medially from the Sevian fissure. Lateral to the optic chiasma. As you can see, after a retraction of the optic chiasma, we can clearly see the anterior cerebral artery. And it is below the anterior perforated substance. It causes, as we can see, anteromedially, above the optic nerve or optic chiasma. As you can see, it is above. And below the medial olfactory tract to enter the interhemispheric fissure. This is the interhemispheric fissure of the frontal lobes. Near its entrance into the fissure, as here, it joins to the opposite artery the opposite anterior cerebral artery by an artery called the anterior communicant artery. It then ascends in front of the lamina terminalis to pass into the longitudinal fissure between the cerebral hemispheres, the frontal cerebral hemispheres. This is an exposure of the perforating branches arising from the anterior communicant arteries. They will pass backward to enter into the diencephalon through the region of the lamina. This perforating artery will vascularize the peduncular cerebral, the cerebral peduncular, also known as mesencephalon. The anterior communicant artery has 5 segments, like the other arteries, main arteries. It has A1. It is first divided into 2. The pre-communicating artery, that's the part of the artery which is found before the anterior communicating artery, and we have the post-communicating artery, which is made up of 4 segments. The A1 or pre-communicating artery will extend. The A1 will extend from the origin of the anterior cerebral artery to the anterior communicant artery, just before it enters the interhemispheric space. It crosses above the optic chiasma, as you can see, or usually the optic nerve, to join the anterior communicant artery. We have to note that in pathology, when you have an hypoplasia of the pre-communicating segment of the anterior communicating artery, it is usually associated or result into an aneurysm, of the anterior communicant artery in 85% of the cases. This artery has 2 segments. It has a posterior superior segment and a posterior inferior segment. This posterior superior segment which vascularize the optic chiasma, part of the optic chiasma or the optic nerve. It also vascularizes the anterior hypothalamus, the general of the internal capsule, and the anterior part of the globus pallidus. While the posterior inferior segment will vascularize the optic nerve, the optic chiasma, and sometimes the optic tract. The A2 segment, also known as infracallosal segment, will give 3 important branches. There is the recurrent artery of Hertner. The recurrent artery of Hertner is the recurrent artery of Hertner. It irrigates the internal capsule. You can see the internal capsule, particularly the posterior limb of the internal capsule, and also irrigates the putamen. It will also give the orbitofrontal artery, which will irrigate the gyrus rectus of olfactory bulb and tract. It will also give the frontopolar artery, which irrigates the pole of the frontal lobe. That image is less illustrative. So this is the A2 segments. The A2 segment, which is divided into the recurrent, is the recurrent artery of Hertner. This is the frontopolar lobe or orbitofrontal lobe. So it vascularizes the frontoorbital, so the frontopolar lobe vascularizes the pole of the frontal lobe, while the orbitofrontal lobe vascularizes, as we said earlier, the olfactory bulb or tract. We have another image of A2 here, which will give the recurrent artery of Hopner, and will give other two arteries. We also have A3, also called a pericallosal artery. The pericallosal artery gives three main arteries. We have the callosomarginal artery, which will vascularize the portion of the premotor, motor, and sensory portions of the frontal, temporal, and the parietal lobe medially. It also gives the anterior and middle internal frontal artery, which will vascularize the posterior, third, and superior of the superior frontal gyrus and part of the cingulate gyrus. So we have our A3, which will give the callosomarginal artery. It also gives the internal and middle, the anterior and middle frontal arteries, as you can see. The callosomarginal arteries penetrates deeply to vascularize the portions of the motor, sensory, and the portion of the motor and sensory areas of the parietal frontal bones, respectively. We then have A4 and A5. A4 and A5 are found above the corpus callosum, as you can see. And they divide into two: an anterior part, which is A4, which will give the paracentral artery, which vascularizes, which is a deep branch, which vascularizes the premotor, motor, and somatic sensory areas. While the A5, which is the posterior part, will vascularize the superior portion of the precuneus and the posterior inferior part of the precuneus. This is an image showing A1 and its perforating branches. This is another image showing A1. A dissection of A2 has been made to better see A1, this from an inferior view. An inferior view. Thank you for your attention.
Okay, Nathalie, thank you very much. Excellent. Oh, there we go. I'm sorry. There we go. Natalie, thank you very much. Let me get to the speaker mode. Well illustrated, clear. And one of the values of these conferences is the networking. You can get off the screen share there, Natalie. Just is meeting the other people at the conference. So let's go around again and introduce yourself, please. Okay, we'll start with you, Nathalie. Can you please introduce yourself to everybody? Because we have some later arrivals.
Hello, everyone. I'm Nathalie. I'm a medical doctor, general practitioner in Cameroon. And I'm also a member of the African Association of Future Neurosurgeons.
Very good. Okay.
Created by RSC.
Marco, are you there? I'll introduce the neurosurgeons first. Go ahead, Marco.
Hello, everybody. My name is Marco Meloni. I'm a consultant neurosurgeon in Italy, northern part.
Okay, welcome. A frequent participant here. Naru, could you please introduce yourself?
Hello everybody, I am Nuru Bankol. I am in my 5 years of the residence course in Morocco here in WFNS Reference Center of Training of Young Neurosurgeons in Africa. Thank you to come everyone.
Okay, one thing that Naru is showing us is that when you're low on bandwidth, sometimes you have to turn the camera off so that we can hear you, because the audio part is really the more important. Okay, Emmanuel, could you please introduce yourself and welcome?
Yeah. Hello, can you hear me?
Yes, we can.
Yeah, my name is Emmanuel. I'm a first-year postgraduate student from Russia and working at the Institute of Neurosurgery, also known as Brodenko, Russian Federation.
Oh, wow, that's a big institute in Moscow, right?
Yeah, in Moscow. I guess you all know that, right?
Well, the name rings with me ever since being involved in neurosurgery and the Russian neurosurgeons, Dr. Sufinov and Tayuman. I don't know if you know his name, but anyways, let's continue with the introduction. There's a gentleman I met online from the Dominican Republic, Johnson. Could you please introduce yourself to everybody?
Hi, doctor.
Yes, could you please tell where you're at and etc.?
Hello.
Yes.
Hello.
Yes, we can hear you. Can you hear me? Maybe not.
Yeah, I'm Johnson Senatus. I'm Asian. I live in Dominican Republic. And I will study neurosurgeon.
Okay, very good. Welcome. Bienvenidos. El también va a participar en nuestra otra canal. Dylan, could you please introduce yourself? Where'd you go, Dylan?
Hello everyone. I'm Dylan from Cameroon. I'm 7th-year medical student and a member of the Association of Future African Neurosurgeons. Nice to meet you all.
Welcome again, Ulrich. Ulrich, are you there? Okay. Yeah, go ahead, Ulrich.
Yeah, thanks, John. Hello, everyone. Ulrich Sidney here, final year medical student and future research associate at the Harvard's program in PGSSC. Nice to meet you all.
Very good. Welcome. Okay, Jack, MD. I don't know if you can hear. I believe Jack doesn't have a microphone. Dr. Kabulo, we missed you there. Are you still there?
Yeah, of course. Hello, everyone. Sorry, my light is poor. My name is Kabulo from Congo. I'm final year neurosurgery resident at the University of Zimbabwe.
Doc, I hate to say this, but you have to smile so we can see you.
Hope today you're not going to mention Mozambique.
Okay. Very good. Okay, I think it wraps up everything. Does anybody have any comments or questions for Nathalie? Marco, you're an anatomist.
Well, just 2 words, John. Well done. Is absolutely perfect. Very extensive. Is the residency lesson in the cerebral vascular surgery. So, just my congratulations, Natalie.
Thank you. Thank you. Okay.
Thank you, Dr. Marco. Thank you.
Go ahead. Did someone say, Natalie, you saying something?
I was saying thank you to Dr. Marco. Thank you very much. And thank you for being with us every time. Thank you.
You're welcome, darling.
Okay. Any more comments or observations? Okay, well, I'd like to thank everyone for coming. We'll just wrap this up now. I'm going to leave it on the live cast if you want to just stick here. And I do want to talk to Senatus. Okay, thanks everyone, and we'll see you next week. What is it? What is the conference next week? Could you just
John, there's hydrocephalus by Dr. Neuro.
Peripheral nerves.
Today.
Are you giving it, Nathalie?
Yeah, it was supposed to be today. You gave it on. You put it on the flyer.
Oh, okay.
Yes.
Okay. Very good.
I'm gonna do my presentation now. If you are ready.
Let me just wrap this up for editing purposes, okay? Oh, no, I'll tell you what. Let's continue. I'll just edit this part out, okay? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett with Neurosurgical TV headquarters. I'd like to introduce today Naru Dine. He's a neurosurgical resident from Morocco. Before we turn it over to Naru, let's just quickly go through the panelists. Could you please introduce yourself? Hawaii.
Okay, thank you, John.
Hold on, Naru. Well, I'm just introducing the people here first. Hold on. And then we'll turn it. Hello, Hawaii, are you there? No, I guess not. Can you unmute yourself and introduce yourself? Okay, we're having trouble. Okay, Emmanuel, we'll try again. Go ahead, Emmanuel.
Okay. Hello, guys. My name is Emmanuel, first year postgraduate student from Russian Federation.
Okay.
Nice to meet you all.
Thank you. And once again, Johnson, could you please introduce yourself? Johnson, go ahead.
Hey, thank you for the information about this, and I will like.
Okay, well, this is just introducing yourself. Just introduce with your name and where you're working, etc.
Okay. So
okay.
It's Johnson, and I'm medical student.
Okay.
And I live in Dominican Republic.
Okay. Bienvenidos. Muchas gracias. Okay. Let's see. Who else? Ulrich. Once again, could you introduce yourself?
No trabajo.
Oh, hold on, Johnson. We're introducing the other people. Ulrich, are you there?
No. Hello. Hola a todos.
Bienvenido. Very good.
¿Cómo estás?
Thank you very much. I'm Ulrich Sidney. So I'm final year medical student and a future research associate at Harvard. Nice to meet you all.
Welcome. And Jack MD is not there. And Dr. Kabulo, are you there again? Could you please?
Yes. My name is Kabulo from Congo. I'm currently final year neurosurgery resident at the University of Zimbabwe.
Okay, welcome. Okay, Naru, it's all yours and welcome.
Thank you, John. And I'm gonna share my screen.
Could you please introduce yourself, Naru, and what you do and where you work, etc.?
Okay, I am Nuruddin Bankol, and I am resident in neurosurgery. I am in Rabat, Morocco, WFNS Reference Center Training of African Neurosurgeon. I am in 3rd years of my training course.
Very good.
And, nice to meet you, and thanks all to come to support our neuroanatomy, school anatomy lecture today. Thank you, everyone. Do you hear me?
Yes, we can see it well. We can hear you well.
Okay, so now I share my screen. I don't know if you see that.
Yes, it's perfect. It's perfect.
Okay, so I will go ahead and start my presentation.
Yes, please.
Okay, thank you. So today I will talk about hydrocephalus. I will use this plan introduction. I will talk about anatomy, physiology, and background, physiopathology and clinical diagnosis, paraclinical diagnosis, etiology of hydrocephalus, and the management. And I'm gonna talk after about prognosis and conclude it. The term of hydrocephalus is derived from two words. Hydro meaning water, and cephalus referring to the head. Hydrocephalus is a condition in which excess of cerebrospinal fluid builds up within the ventricles, fluid contained cavity of the brain, and may increase pressure within the head. Although hydrocephalus is often described as water on the brain, the water is actually CSF, a clear fluid surrounding the brain and the spinal cord. Hydrocephalus can occur at any age, but it is most common in infants and adult age 60 and older. According to the National Institute of Neurological Disorder and Stroke, hydrocephalus is believed to affect approximately 1 in every 500 children. The majority of these cases are often diagnosed before birth, at the time of delivery, or in early childhood. We have clinical form in infant, children, younger adults, and older adults. I will go quickly about anatomy because Dylan was done this topic last Friday. So from an anatomical point of view, the CSF is divided into two main systems, the ventricular systems, who contain the lateral ventricle, the third ventricle. They communicated with each other, and we have the extraventricular system composed of arachnoid space, pericerebral, and perimedullary space. The hydrodynamic of CSF is explained by three phenomena: secretion, circulation, and resorption. About the ventricular system, we have 4 ventricles lodged inside the brain, are described, they communicated with the subarachnoid space and the arachnoid system of the base skull. They are lined by a particular epithelium called ependyma. So we have 2 lateral ventricles. We have 2 lateral ventricles, semicircle shaped cavities, open forward around the basal ganglia. Each cerebral hemisphere has a lateral ventricle. They are described 3 horns. We have 3 horns: frontal horns, temporal horns, and occipital horns. The junction of the 3 horns is the ventricular junction or atrium. Both ventricles are separated by a septum called the septum pellucidum. The lateral ventricles have a capacity of 10 milliliters and communicated with the third ventricle by the Monroe holes. It is the interventricular foramen, which measures 8 millimeters in diameter. The third ventricle has a quadrangular shape, dragging the diencephal, measuring 25 long and whose walls are 5 millimeters apart. It communicated with the fourth ventricle via a filiform canal running through the midbrain, measure 15 millimeters long and 2 millimeters wide. These holes means the aqueduct of Sylvius. You can see here the aqueduct of Sylvius. This it is the third ventricle, and this it is the fourth ventricle, and here we have the 2 lateral ventricles. The fourth ventricle is an odd cavity located between the brainstem forward and the cerebellum behind. It has a lozenge shape, like you can see here. That's a lozenge shape, like that, like this here. It's communicated with basal cisterns and subarachnoid space via 2 foramens, the Luschka foramen holes at the lateral angle and the Magendie hole measuring 4 mm to 6 mm located at the lower part of the fourth ventricles. These anatomic features are found during intraventricular video endoscopic procedure. I will go ahead about extraventricular system. We will have the subarachnoid space, who is limited by the arachnoid and the pia mater. The pia mater closely intimate contact with the surface of the cerebral cortex as well as the spinal cord. At the base level, we find the arachnoid tank whose main ones are the chiasmatic cistern, the basal cistern, the ambient cistern, and the cisterno-medullary cistern of the large cistern. You can see here the large cistern, the ambient cistern, and the fourth ventricle here. The physiology of CSF rests on three phenomena, like I was told in my introduction. It is the secretion of CSF, the resorption of CSF, and the circulation of CSF. When we have disturbance of one or more of these factors, cause hydrocephalus. So, about secretion of CSF at the level of the CSF was secreted at the level of the choroid plexus, which are vascular structures located in the lateral cerebral ventricles. 150 milliliter total on encephal and spinal cord will secrete between 4,150 and 7,150 milliliter per 24 hours. The CSF is renewed 4 to 5 times per day. About circulation of CSF, we have the CSF come from plexus choroid in lateral ventricle and come to the third ventricle pathway Monroe holes, and then Sylvius aqueduct, and then fourth ventricle, and after we can go to the subarachnoid space and cisterns through pathway Magendie and Bluchka holes. The brain, spinal cord, and nerve roots are surrounded by the CSF. CSF resorption at the level of the arachnoid villi, which are invaginated in the superior longitudinal sinus. CSF pressure, intracanal pressure, we can have 10 to 50 millimeter mercury on the child and 50 to 20 millimeter of mercury in adults. If CSF volume increase, we can have increased intracranial pressure. What about physiopathology? Acute hydrocephalus revealed by increased hypertension, intracranial pressure syndrome can be explained by several mechanisms, like obstacle to the circulation of CSF at the origin of an obstructive or non-communicating hydrocephalus, dilating a part of the ventricular cavity. Resorption disorder causing obstructive or non-communicating hydrocephalus, dilating part of the ventricle, and sometimes the subarachnoid space. We can have hypersecretion of CSF, who is rare. Hydrocephalus is often categorized for age group as either congenital or normal pressure hydrocephalus. Congenital hydrocephalus refer to conditions that are caused by conditions existing at birth. Primary symptoms include headache, nausea, vomiting, and drowsiness. Normal pressure hydrocephalus NPH, it is the accumulation of cerebrospinal fluid that causes the ventricle in the brain to become enlarged with little or no increase in pressure. Adult onset NPH mainly occurs in adult age 60 and older. Sometimes patients with NPH often get misdiagnosed with Alzheimer's disease or dementia as some of symptoms mimicking these two conditions. Hydrocephalic are communicating and non-communicating. If the cerebrospinal fluid flows freely throughout the brain's ventricular system and the subarachnoid space, it is referred to as communicating hydrocephalus. If there is a physical blockage, such as a tumor somewhere in that system, it's called non-communicating hydrocephalus. I will go ahead about clinical diagnosis, and I will talk about different forms of hydrocephalus. We have infant forms, who is different from the adult form. The child cannot say that is hurt because it is child. The sutures are not made yet. Incohesive head circumference, like macrocephaly, can be occurred. Anterior fontanel bulge, suture disjunction, cephalic cutaneous thinning, and hydrocephalus therefore increased intracranial pressure with result in oculomotor disorder like strabismus, a decrease in the visual acuity of the child, and like you can see in this picture, appearance ears of the setting sun. We can have like a symptom like anorexia, vomiting, apathy, irritability, and disturbance of consciousness and the focal neurological deficit. That is about infant forms, symptoms of hydrocephalus. About children forms, we can have abnormal enlargement of baby's head. We can have headache, nausea, vomiting, fever, blurred or double vision, unstable balance, and irritability and sleepiness. Delayed progress in walking or talking, and the poor coordination, change in personality, inability to concentrate, loss of sensory motor function. We can have seizure or anorexia. All the children may experience difficulty in remaining awake or waking up. If the hydrocephalus is low and long-standing, some children can have delay in their developmental milestones or poor learning in school. About young and middle-aged adult form, we can have just headache, difficulty in remaining awake or waking up, loss of coordination or balance, bladder control problems, and impaired vision and cognitive skills that may affect job performance and personal skills. About older adult form, like you can say in normal present hydrocephalus, we talk about Hakim and Adams triad. You can have loss of coordination of balance, ataxia, apasie, you can shuffling gait, memory loss, and headache, and bladder control problems. I will go ahead about paraclinical diagnosis. Transfontanelar ultrasonography is the first line examination in an infant suspected of hydrocephalus in front of macrocranium. You can see here ultrasound transfontanelar posterior coronal cup, asymptote the heart, occipital lateral ventricle like hydrocephalus here. CT scan, we acknowledge an increase in the size of the ventricles, ventricular hydrocephalus, who showed here the dilatation of third ventricles and two lateral ventricles with an almost normal size of the fourth ventricle. So it is tetraventricular hydrocephalus and disappearance of cortical transependymal resorption. MRI help to specify the etiology. Like you can see here in this MRI, T2 sequence, fluid attenuated inversion recovery, and sequence T1, gadolinium, show triventricular. You can see here the occipital horns of lateral ventricle who is dilated, and third ventricle dilated, and this expansive process was developed in the posterior part of the third ventricle, who is the cause of this triventricular hydrocephalus. Another case about hydrocephalus by hypersecretion of CSF secondary to a papilloma of plexus choroid with important dilatation of tanks from the base. I will talk about etiology, the common cause of congenital hydrocephalus and common cause of acute hydrocephalus, like secondary cause. So we can have malformation of the base of the skull, of the ventricular system, like malformation Dandy-Walker, malformation of Chiari type 2, agenesis and obstruction of the intraventricular foramina, and common cause of acute hydrocephalus secondary to a brain tumor, in particular the tumor of the posterior cerebral fossa or cerebellum, to a cerebral meningeal infection like abscess and meningitis. We can have hemorrhage. The blood is too viscous and blocks the passage of the CSF, like subarachnoid hemorrhage when we have aneurysm ruptured. We can have intraventricular and intracerebral hematoma. The common cause of congenital hydrocephalus, like aqueductal stenosis, the most common cause of congenital hydrocephalus is an obstruction called aqueductal stenosis. This occurs when the long, narrow passageway between the third ventricle and fourth ventricle is narrowed or blocked, perhaps because of infection, hemorrhage, or a tumor or malformation. Fluid accumulates upstream from the obstruction, producing this hydrocephalus. Like you can see in this case, stenosis. Here, there is no passage, stenosis aqueduct, and we see dilatation of ventricle apart. Common cause of congenital hydrocephalus, like neural tube defect. Another common cause, an open where the spinal cord is exposed at birth and is often leaking CSF, is called a myelomeningocele and is often referred to as spina bifida. This kind of neural tube defect usually leads to the Chiari-2 malformation, which cause part of the cerebellum and the fourth ventricle to push downward through the opening at the base of the skull into the spinal cord area, blocking CSF flow out of the fourth ventricle and causing hydrocephalus. You can see this myelomeningocele who causing about this enlarged ventricle. We can have arachnoid cyst, who is congenital hydrocephalus and can also be caused, which may occur anywhere in the brain. In children, there is often located at the back of the brain, posterior fossa, like in these cases. And in the area of the third ventricle, these cysts are filled with CSF and lined with arachnoid membrane, one of the three meningeal coverings. Some arachnoid cysts are self-contained, while the others are connected with the ventricle of the subarachnoid space. So the fluid trapped by the cyst may block the CSF pathway and causing hydrocephalus congenital. Dandy-Walker syndrome, another cause of congenital hydrocephalus, the fourth ventricle here becomes enlarged because its outlets are partly or completely closed and part of cerebellum fails to develop. Like you see here, agenesis, cerebellum agenesis. Dandy-Walker syndrome may also be associated with abnormal development in other parts of the brain and sometimes leads to aqueductal stenosis. In some instances, two shunts are placed in the child's ventricles, one in the lateral ventricle and another in the fourth ventricle to manage this hydrocephalus. We can have Chiari malformation. There are two types of Chiari malformation. Both types occur in the bottom of the brain stem, where the brain and the spinal cord join. The lowest portion of the brain is displaced and is lower than normal, pushing down into the spinal column. Common cause of acute hydrocephalus is the intraventricular hemorrhage. An intraventricular hemorrhage which most frequently affect premature newborns, may cause an occur from hydrocephalus. When small blood vessel alongside the ventricular lining rupture, blood may block or scare the ventricle or plug the arachnoid villi, which allows CSF to be absorbed. When the CSF can't be absorbed, hydrocephalus results. We can have common cause of acquired hydrocephalus like meningitis. Meningitis is an inflammation of the membrane of the brain and spinal cord caused by a bacterial or less frequently viral infection. Meningitis can scar the delicate membrane called meninge that line the CSF pathway. I can see here this meningitis cause this quadriventricular hydrocephalus. Occur of hydrocephalus may develop if this scarring obstructs the flow of CSF as it passes through the narrow ventricles or over the surface of the brain in subarachnoid space. We can have a head injury who can damage the brain tissue, nerves, or blood vessel. Blood from rupture vessel may enter the CSF pathway, causing inflammation, and we can have seeds of CSF absorption might then be blocked by scarred membrane meninge or by blood cells. The CSF flow is restricted and we will have hydrocephalus development. We can have brain tumor. In children, brain tumor most commonly occur in the back of the brain, which is referred to as the posterior fossa. As the tumor grows, it may fill or compress the foreventricle, blocking the flow of CSF and causing hydrocephalus. A tumor somewhere else in the brain might also block or compress the ventricle system like here. I will go ahead about the management. What is the goals about the management? The goal is to restore the circulation of the CSF and derivation of this one to treat and after to treat the cause of this hydrocephalus. In emergency, we can't wait. We have to do something, so we can go to external ventricular lead, soft kit implanted in one, a soft catheter implanted in one of the two lateral ventricles in the frontal horn, through the skull and the cerebral parenchyma connected to a pocket by a tubing system. Flow depending on the position of the pocket relative to the ventricle. Transient device, but we can have higher infection risk, so you have to pause and care with great asepsis. And the indication is in hydrocephalus, in hemorrhagic context, or in infection context. So you can see here this dispositif, this device, external ventricular drain, this column, and this drainer bag for CSF. Outside the emergency, we have to perform valve of diversion, compound device, superior catheter, support catheter, in the ventricular system or ventricular junction, connected to a valve, placed under the skin, which regulates the flow rate of the liquid. The valve is connected to a lower catheter, which is tunneled under the skin. The lower catheter can be implanted in heart chamber, like right aorta, and through jugular veins. We can call cardiac ventricular bypass, or in the peritoneal cavity, ventricular peritoneal diversion. The complication And risk of bypass valve, it is an obstruction of this catheter, of the catheter ventricular, of the catheter in peritoneal. We can have hyperdrainage, like, and occur subdural hematoma, or infection, local cutaneous, meningitis, peritonitis, and endocarditis. You can have hemorrhage if you sting catheter in the brain. Other treatment nowadays is with endoscopy surgery. It is the ventriculocysternostomy. The aim is to recreate normal CSF circulation by windowing the flower of the third ventricles. Only for certain types of hydrocephalus, like obstructive hydrocephalus. Only for obstructive hydrocephalus, we can perform VCS, ventriculocysternostomy. And this technique gives another route of circulation to CSF. A hole is made with a balloon in the membrane of the third ventricles. The advantage of ventriculocysternostomy, you don't need valve installation, less important infection risk, but we can have complications like intraventricular hemorrhage, vascular wound in basilar trunk, but it is rare. We can have obstruction of the stomach orifice, so the hole is closed, and it is necessary to proceed again. I will talk about prognosis. The prognosis for hydrocephalus depends on the cause, the extent of symptom, and the timeliness of diagnosis and treatment. It is important, the time of diagnosis, the cause, and the extent of symptom. Some patients show a dramatic improvement with treatment, while others do not. In some instances of NPH, normal pressure hydrocephalus, dementia can be resolved by shunt placement. Other symptoms, such as headache, may disappear almost immediately if the symptoms are related to elevated pressure. And in general, the earlier hydrocephalus is diagnosed, the better the chance for successful treatment. The longer the symptom has been present, the less likely it is that treatment will be successful. Prognosis, shunt malfunction or failure may occur. The valve can become clogged, or the pressure in the shunt may not match the need of the patient, requiring additional surgery. In the event of an infection, antibiotic therapy may be needed and likely temporary removal of the shunt and replacement by a drain until the infection clear. And after, the shunt can then be reimplanted. When a shunt malfunction, a surgery is often needed to replace the blocked or malfunction portion of the system of the shunt system. Fortunately, most complications can be dealt with successfully, but we can have death in acute hydrocephalus without emergency management. So, in my conclusion, hydrocephalus are diverse in their physiopathology, their etiology, their clinical translation, as well as in their prognosis. Hydrocephalus at normal pressure is today the subject of all questions. Good collaboration between neurologists, neuropediatricians, and neurosurgeons is essential for better management. And we have always to think about acute hydrocephalus. Thank you for your attention.
Thank you very much, Naru. Let's get you off the screen share there. So just click on the leave screen share.
Thank you, John.
Yeah, I'll do it. I'll do it. Okay, no problem. There we go. I got to stop my screen share. Yeah, excellent. I'm sure students as well as attendings like to get refreshed about that. Okay, let's just introduce a couple of members that came late. Okay, Naru. Nitin, could you please introduce yourself to Naru and myself and all the rest? Go ahead, Nitin.
Hello. Hello, myself Nitin. I'm from India, South India.
Okay, welcome.
Thank you. Thank you.
Welcome. And let's see who else still in. Everyone met him. Anybody else that hasn't been? Hawaii, you want to try again? Huawei. That's all the name I've got to introduce you. I'm unmuting you. Can you take? Okay, go ahead. Go ahead. Please introduce yourself. Can you hear me okay? Well, maybe not. Okay. Okay. There's Hugues. Hugues Christian. Could you please introduce yourself? I don't think we've met you yet.
Okay, thank you, sir.
Could you please introduce yourself?
Yeah, my name is Christian. I'm a resident at the hospital of Ibn Sina in Rabat.
So, John, I will present you X. It is a young resident who just started his residence in the same center like me. He is come from Benin, and now he is in Rabat Center WFNS training. And Huawei P9 is Dr. Jose, who comes from Congo. He's in my center here in Rabat, and he's in first year of his residence course.
Yeah, it's a fairly small community of neurosurgeons in Africa, right?
Yes.
I guess if you go to the main conference, you meet a lot of people, right?
Yes, it is.
Yeah, that's great. That's great. Hope we can bring it closer using this tech. But we'll see.
Hello.
Hello, go ahead.
I wanted to ask a question to Dr. Nuru.
Okay.
Yes, go ahead.
I read about the cauterization of the choroid plexus in the treatment of hydrocephalus. I just wanted to ask, I didn't see it in your presentation. So when can you do that? When do you think it is appropriate, or which type of hydrocephalus is appropriate to do the cauterization of the plexus choroid, the choroid plexus?
Yes. Nowadays, I know that with endoscopic procedure, sometimes when we finish to open, we done the stomy, we can cauterize the plexus choroid. That give a good outcome and prevent recurrence of hydrocephalus. So that is to prevent the acute recurrence of hydrocephalus. Sometimes we perform cauterize plexus choroid.
Oui.
It is to prevent the recurrence.
Yes, Dr. John, I have some comments.
Go ahead.
Thank you.
Yeah.
You're welcome, and thank you for your brilliant presentation about vascularization of brain. Thank you, Natalie.
Go ahead, Dr. Kabulo. Are you there still?
Yeah, it's okay. Thank you, Dr. Nuru, for your presentation. I have few comments on your presentation. Like, I think this is like we are doing the basic sciences, since we have also medical students among us. So, like when you are talking about hydrocephalus, you are talking about physiology of CSF production. It was also good to mention few and small things like how it is produced, in how many percent in lateral ventricles, in fourth ventricles, in the spinal cord, how much CSF is produced there. And at the beginning, you mentioned that there are two types, congenital and normal pressure hydrocephalus. Congenital and acquired. I think it was okay now when you were mentioning now about, we were talking about etiologies, you mentioned now congenital and acquired. Also, when like you are thinking about CT scan, on CT scan, how to recognize hydrocephalus, since we have medical students, small things, how to see if there's hydrocephalus. like measure the Evans index, okay, how to measure the temporal horns of lateral ventricles for you to diagnose hydrocephalus. So you should also mention those small things. And also, you said neurotube defect leads to Chiari. It's in the Chiari malformation where you get those things. And also, you said myelomeningocele causes enlarged ventricles. It's not the myelomeningocele which is causing hydrocephalus actually, because it's in the syndrome called Chiari malformation. It's that Chiari because you have downward displacement of cerebellar tonsils, which is now obstructing the flow of CSF. Then you get hydrocephalus. So in that syndrome, every child with hydrocephalus, you have to check if there is a myelomeningocele, spina bifida, and if there's club foot, then you talk about that syndrome called Chiari 2 malformation. So it's not the myelomeningocele which is causing hydrocephalus. So also you mentioned there are 2 types of Chiari malformation. There are not only 2, there are many. There are many actually. Yes. They are not talking about Chiari 0, Chiari 1, Chiari 1.5, Chiari 2, Chiari 3, Chiari 4. So there are many. There are not only 2. And another thing I wanted to mention, it was about meningitis. Of course, it's an infection. Usually you get exudative, whatever, at the base of the skull. You get healing by fibrosis on the arachnoid granulations, which is reducing the reabsorption of CSF. You get the infection. And so those are just small things I just picked up, maybe for future. And it's a huge topic. Since we have medical students, if we can share, like, you talk about physiology of CSF, physiology or causes of hydrocephalus, and treatment, just one day about treatment, it would be okay. Instead of getting everything the same day, it's a huge topic. And also, make sure that every time you are presenting, you should also add your references so people can see where you got the information from. So we didn't see your references. Otherwise, well done, and we are encouraging you. Thank you.
Thanks, Dr. Kabulo.
Yes, thank you, Mr. Kabulo. All you say is right, and the goals of this presentation, it is to highlight and done summary about hydrocephalus, because I can talk about all and go in about all details here. And I talk about physiology. I talk about that when I start my presentation. And you are right, we don't have just 2 types of Chiari malformation, like you said, I agree. But the common, I talk about the commonly type who give hydrocephalus, and it is the types 1 and 2. And like you say, it is, you are right about myelomeningocele. Yes, I know it is the it is all this syndrome who called. I know what I understand what you said, and thank you for all your comments, and thank you.
Very good. I'd like to take this opportunity to introduce a couple of late-coming panelists. Jack, MD, could you please introduce yourself?
Yes, thank you. My name is Jackson Chiwaligo. I'm a medical doctor from Tanzania, working at the district hospital. I am a neurosurgical aspirant. Thank you.
Very good. Very good. We've had a few doctors from Tasmania. Dr. Kabulo, he's not in Tanzania. He's in Mozambique. Okay.
Zimbabwe.
I'm sorry. It's Zimbabwe. I'm sorry.
Yes.
I'm sorry. Okay. Yehundi Tessie, could you please introduce yourself?
Yeah, I'm Dr. Yehundi Tessie from Benin. I'm in radiology in Medical Hospital of Mohamed Sink of Rabat. Nice to take part of conference.
Very good. You're welcome to any of our conferences. And we have your emails, right? Everyone, because we usually send out emails of notices. Did you get an email from us this time? Or leave your email, please. Put it in the chat. Yeah, put it in the chat box. You see where the chat is at the bottom? Chat.
Okay.
Yeah, click on the chat and just leave a message for me, or an email.
Okay.
Or just get through me from Facebook. You're probably a friend of mine on Facebook, John Bennett, MD. So I'm also there. So you can find me. Any remarks, Marco, for Naru?
Yeah, John. First of all, I want to congratulate with Noro. Is a very good presentation. Obviously, in just one presentation, we cannot talk about all the cerebrospinal fluid physiology, because we know at this time more and more about physiology, that it cannot be reduced just by a very simple concept like obstructive and communicating hydrocephalus. We're knowing more and more about the cerebrospinal fluid circulation. And another thing I want to ask to Noro, in your department, what's your procedure to diagnosis normal pressure hydrocephalus? You perform tap test, or you perform something more elaborated?
Naru, did you hear all that, Naru? Hope we didn't lose him, because I can't answer the question.
Oh, no problem.
Naru, did you hear that question? Naru, did you? I see you on the screen there. You're not on. Whoop. I think we're just having a little. We'll get him. He'll come back, I'm sure. Naru, are you there? Can you hear me? Okay, I unmuted you. Try to unmute you. I'm sorry, we're having a little technical. We'll get it though.
No problem.
Unmute. Go ahead, Naru. Are you there? Unmute yourself. I'm trying from one area. Let me try another area. Okay, go ahead, Naru. Go ahead. Naru? Oh, I'm sorry. I think it may be bandwidth because of now we're losing the. Can you hear me, Naru, at all? Well, we can go on. And any other comments or questions from the panel before we sign off? Well, I'd like to thank you.
I think my last comment, maybe we...
Go ahead, Dr. Wall.
Yes, in consideration what Dr. Marcos said. So we have huge topics, and this is like we are doing basic sciences in neurosurgery. So we can share a topic even in 3-4 presentations, then we discuss in details. Yeah, thank you.
Okay. I think Naru got back in here, I think. Naru, are you back? There he is. Okay, one sec. Okay, Naru, can you hear? Just give us a second here. Unmute. I'm trying to unmute you from a different spots, but not having success, Naru. Well, okay, Naru. I have to thank you very much, and we're going to sign off because we're just having too hard a time unmuting you. But we're learning this tech. We're getting better slowly but surely. And once again, thanks for all the panelists. We're having good turnouts. This is great. And I'll send you the copies of this broadcast will be on Facebook as well as Neurosurgical TV. Any ideas you guys have on using this platform for education in neurosurgery, let me know. They're fun, they're informative. You meet people from all over the world like this one, and they're of educational value, as you saw those 2 great presentations today. So we'll be signing off, and thank you very much.